Good morning everybody in the room and on webinar land, and welcome to another Insight APSAD webinar. My name is Jim Hunt, I'm one of the nurse educators here at Biala, and today we're going to have a conversation about managing HIV, the HIV virus to some degree. First, I would like to acknowledge the traditional owners and custodians of the land on which we meet today and pay our respect to elders past, present and emerging. And obviously I would like to extend that respect and welcome to anyone in the room or on webinar land that's of Aboriginal or Torres Strait Islander descent. So welcome. And it gives me great pleasure and privilege today to introduce a nurse practitioner, Jacqualine McLellan, who's one of our own. She's in this very building and works in the Sexual Health and HIV service down on the first floor. And I will let her come up and give her presentation on PEP and PrEP in relation to HIV. So thank you, Jacqualine McLellan, if you'd like to come up.
Thank you, Jim. And welcome to everyone both in the room and online. I'll also reflect on Jim's recognition of the traditional owners of the land, and also in the area that I work in, anyone that is from culturally diverse and gender diverse communities that might be listening, and pay my respect to them. And this, certainly in the presentation, I would hope that it's representative of being inclusive for everybody. So just with a little bit of background, my experience has come from the reproductive and sexual health background, and mostly women's health in the last 10 to 20 years. So I'm reasonably new to HIV. I've been a nurse practitioner downstairs for almost 12 months, and HIV is fairly new within the last 2 to 3 years. So whilst I'm not an expert, I certainly do manage an HIV cohort. Those people are people that are incarcerated at the moment, and certainly I do appreciate that there's certainly a crossover between people with drug and alcohol issues for those people as well. They're quite complex and they have diverse needs. So with the reason that this year's been extraordinary, I believe, but for 3 reasons. We have marriage, diversity and equal rights for all people. We have recently had legalised abortion laws in Queensland, and we can now say, with the evidence that we have, that HIV virus, when a person is on antiretroviral therapy and undetectable, that equals untransmissible of that virus to their sexual partners. Now we'll get into a little bit more research around that, but predominantly that has now been evidence-based, and we have been able to present that since the Sexual Health and HIV conference earlier this year in Amsterdam, 2018. And the evidence for that has roughly been based on 2 4-year studies, Partner 1 and Partner 2 studies, where heterosexual couples, discordant couples were recruited into those trials, both gay and heterosexual couples, where one partner was HIV positive, the other partner wasn't, and gay couples also. And in those cohorts of the people that were specifically monogamous with their HIV positive and HIV negative partner, there was 0 transmission in those cohorts over that 4-year period. Now that doesn't mean that there weren't any HIV transmissions, there were, but of those people that became HIV positive within those trials, the virus was genotyped with the HIV positive partner, and those viruses were actually found to be transmissible from other partners during that time. So there were people that were in open relationships and having sex with other partners, condomless sex at that. So this is where that evidence has actually come from. And that will be an ongoing thing, obviously. There can be lots of variables that will influence HIV viremia and the stability of that, other health morbidities. There can be mental health issues where people may not be taking their medications, so there can be escape of virus and detectable viral loads. But overall, we can be confident in saying that now to people. And that will help with hopefully diminishing the stigma both in society and for the people that are HIV positive and live with that stigma all of the time. Okay. So the way I've approached this is through my model of care. and I work with another nurse practitioner in the sexual health service, Adam, and we are both now able to prescribe and assess people for PEP and PrEP. And I guess with HIV medication and management to keep people's, or assist in keeping people in an undetectable time frame, what we're actually looking at is other strategies that we can institute to help people that may have been in contact with HIV to maintain that untransmissible, undetectable status in people that are currently HIV negative. And that's through the provision of PEP and PrEP. So PEP, I'm sure everybody knows, but just in case they don't, PEP stands for post-exposure prophylaxis. And that may happen for people that know the HIV status of the people that they're having sex or perhaps intravenous drug use with. And PrEP is the pre-exposure prophylaxis modality where we're looking at more behavioural risk and prescribing PrEP. And as of the 1st of April this year, that has been subsidised on the PBS, and that can be freely accessible by nurse practitioners to do that prescribing, and also with GPs in general practice. So not just in sexual health clinics and infectious diseases doctors. Okay, so the objectives, hopefully we'll have an understanding of PEP. And that doesn't mean that I don't realise people may already be in an area where they may be identifying people that know that they've had a risk of HIV, and so they may access you as their clinicians and ask, how do I get it? How do I activate this? Where do I initiate it from? And relating the PEP guideline to clinical practice, identifying at-risk clients and the priority populations, and referral pathways for clients who may be eligible for it. So is anyone in the room or online actually prescribing PEP and PrEP to people? I would imagine certainly you would be identifying people that may be exposed through your clinical practice. Possibly. Okay. So, as I mentioned, it's the initiation of medication. We've got a 72-hour window period, and that can sometimes be a little bit grey for some people, where they may be concerned about the known or the potential risk or the known risk of the person that they were with that has HIV. So the aim of providing PEP is to reduce the possibility of transmission by initiating treatment, ideally ASAP, but after 72 hours it is arguable as to whether or not there would be any benefit in the prevention of the transmission in that time. Now, all accident and emergency services, you may know, have the availability of initiating a starter pack, 3 to 5 day starter pack, that will provide the medication. It may be 2 drugs, which the trade name is Truvada, but essentially the components are the same, tenofovir, disoproxil fumarate and emtricitabine, and if there's a known HIV risk where that person may not be on medication or they have a detectable viral load, we may initiate 3 drugs and introduce another drug into that. People can then be referred either to a GP, that's an S100 prescribing doctor, or into sexual health clinics for the ongoing supply. Essentially, PEP is provided for 28 days. In 2016, the guideline for occupational and non-occupational exposure to HIV for the Society of HIV, Viral Hepatitis and Sexual Health Medicine as the current guideline that we're using. I've put the link there, but anyone that is familiar with ASHM, all of these resources are available there, and the evidence base behind it is there as well. So in relation to that, to extrapolate a little bit further, there currently isn't any randomised controlled trials that inform the actual modality of PEP. It's a bit like, I guess, a bit like emergency contraception, in as much as it's the after event chemo prophylaxis, where we're trying to prevent that attachment of HIV virus to the CD4 cells and then ongoing infection. So the data has been extrapolated from animal research, mother-to-child transmission, and occupational exposure and case control studies, and these are PEP regimens in HIV men. And there are specific guidelines around in different states and territories that lead into that. So what's new to the current guidelines for PEP is traditionally there was a an extensive counselling process that we went through people, which involved all sorts of things. Well, if you become positive, it may affect insurance, and often people were so traumatised by that they were quite baffled at the end. Well, do I take this or don't I? Sometimes there can be a lot of anxiety, as you can imagine, when people present for this, not knowing, is it going to be something that I need to take? How do I know? And my role as a clinician is to separate what we do know, the fact, the epidemiology, and to provide someone with information that we can both arrive at the right outcome for them as to whether or not they do or they don't take PEP. And the aim of that is that it's for the benefit of harm as opposed to the benefit of risk and disadvantage. So the medications that are approved are tenofovir and tricytamine, or tenofovir and lamivudine, and they're recommended as the preferred 2-drug PEP regimen. Dolutegravir or raltegravir or ralpivirine are recommended as the preferred third agent for 3-drug PEP. We can, at the moment now that we have PrEP, we can talk to people towards the end of that PEP course if people would like to transition on to PrEP, which is why I've put PrEP on the end, even though it's newer. Often we're transitioning people onto that ongoing PrEP prophylaxis at the moment. And that comes down to testing as well and what the risk is at the time. So routine blood monitoring occurs usually at baseline, and then we look at HIV risk around 4 weeks. Traditionally we did blood tests, liver function tests and electrolytes around 1 week, but we don't do that anymore. Usually we bring people back at 2 weeks, and that's for STI testing to check for other things that might have happened. And at that time we can certainly give people some extra support, some further education, see how they're travelling. If people have side effects and determine that they don't want to continue on with that, we provide an open channel of communication, and they can contact us at any time if they're having any concerns. The most common side effects in that first few days or the first week tend to be a bit of dizziness, sometimes some diarrhoea, maybe a bit of an upset tummy, the normal GIT things that we tend to find. Sometimes people can have a little bit of difficulty sleeping, an increase in flatulence, which is pretty acceptable anyway, but overall it seems to be well tolerated. Some people identify or report that they have a bit of dizziness or feel like they're standing on a boat a little bit in the first few days, but that tends to settle. With advice has been added regarding PEP in children, although as you can imagine it's difficult in clinical trials. Often an exclusion criteria is removing people can't be on clinical trials under 18. So we do this with case-by-case basis, and we certainly link in with our sexual health physicians if there's concern around that. We've recently had that situation occur with a 15-year-old girl who was with an HIV positive partner. And so what do we do with that? Because we know that these drugs can have an impact on bone density and sometimes on renal function, and that's established. And gender identity and history has also been added. So common presentations for NPEP are the things that you would probably already understand in a sexual health clinic, certainly, and those presentations include male-to-male sex, which can be anal or oral, heterosexual sex, sexual assault, male-to-male or heterosexual, although the evidence of HIV positivity in people that, and we've looked at data for people that are incarcerated, that have been incarcerated for sexual assault, the HIV risk is very, very low, less than 1.1%. There may be needle sharing or needle assault, needle stick injury in different places, and there can be other trauma where there's a concern of skin exposure, for example, if there's trauma, a broken skin area, and things like dermatitis. So these give you, we're not going to go through everything, of course, this is available in the guideline, but it just gives you a little bit of information, and this is what we look at when we're talking to someone about their potential risk, and is this potentially valuable for you to go on, and what your risk might be. And often, quite often, more often than not, it's usually an HIV unknown status source where the contact has occurred. And I've put the link in for this if anyone would like to have a look at that further. The unknown and the extremely low risks are things like oral sex with someone, and down the bottom it's got a note there for things like human bites would be extremely low risk, to the point that it's not even a measurable risk. And so the data around this is mathematically modelled. So when we talk to people, if people are asking for evidence, we don't really have robust energy. This is meant to be a method to assist in the potential prevention of HIV transmission. And it's hard when people actually want some data and evidence around this, or how well would it work and this is going to stop it. We don't even know the risk. The risk may outweigh, or the disadvantages may outweigh the advantages of taking it if there is zero risk. But, you know, we don't always have access to the information around the source. So many factors modify the HIV transmission and should be considered. So if we know about the person's status, information that we might know about a viral load. Going back to the start, if we know someone is taking their medication and their viral load is undetectable, then we don't need to provide someone with PEP, because they're not transmitting the virus to the level that they're going to infect somebody. So preliminary data shows no transmission has occurred in homosexual or heterosexual couples from a partner with an undetectable load. Undetectable in the Queensland Health Lab is below 40,000 copies, and we say that just because that's the sensitivity of the assay that we're looking at. Looking at the evidence around the medication and how antiretroviral medication works, we cannot stop to the point of zero the viral transmission once the genome is working, and that's been established in the infection in anybody's body. We can reduce it to a certain level with the medications and where those medications act within the CD4 cell, but we actually can't get the viral load and that viremia down to zero. There is a low level of viremia that's ongoing. So the other factors that increase the potential risk of HIV transmission is sexually transmitted infections in the source or the exposed individual, genital ulcer disease, where, as you would be aware, if you've got an exposure, then you've got you already have immune activity there, and so if you've got CD4 cells in the area and HIV in the area, you've got a very close link there. The reason for, and again, I'm not trying to sell ice to Eskimos, you probably are aware of this, the reason that there is a risk with receptive anal intercourse is the physiology within the bowel is that it's an absorptive process. So we know that that's where we absorb our nutrition, fluid, etc. So if there is ejaculate with HIV virus in the bottom, then we know that absorption effect is going to be absorbed straight into CD4 cells if they're there and into the blood supply. So that's why that risk is there. There can be a breach in oral mucosa with integrity when performing oral sex. Again, with oral sex, it's such a low risk, it's not even a measurable risk. But, you know, when we're looking at the assessment around this, for some people, the level of anxiety related to that needs to be taken into consideration when we're providing PEP. So variables. Sometimes there may be a presentation where a partner knows that their partner has had some resistance in the HIV virus. Anytime HIV virus is transmitted to somebody, that particular virus has its own fingerprint. As it's an RNA virus, it can change, and as it changes and reattaches and becomes integrated into the DNA in our cells, it can change, and so there can be antiretroviral resistance within that. So if people stop medication for whatever reason for any length of time, there can be resistance to those drugs, and therefore that particular virus and those resistances will be passed on to the person that is infected. So we need to take that into consideration. There is a potential risk in pregnancy and breastfeeding, and so we need to be mindful of that. So, for example, if someone is exposed to HIV during pregnancy, there's a higher risk of vertical transmission during pregnancy as opposed to someone being HIV positive prior to becoming pregnant. With breastfeeding, there can be that potential risk through breast milk, and if nipples there's broken nipples or blood contamination there, then that can be passed on. With chronic hepatitis B or C, we discuss that with a sexual health or ID physician if you're concerned about that, should we, shouldn't we? We know that tenofovir works very well in suppressing virus with hepatitis B, so if that person is currently well with their hepatitis B virus, if we initiate tenofovir and then we stop it, we have to be concerned about will that person have a flare, and if you're familiar with Hep B you would know that better than I. How do we know which drugs to prescribe, 2 or 3? One example of this, I like to give clinical scenarios. Sometimes I find it helpful. That helps me in my learning. So we've had a client that's come in with her partner. He was released from prison, and when he was incarcerated, he determined that there's not always a lot of privacy around having HIV medications provided to people when they're incarcerated. So sometimes people determine that if they're there for a short time, they're just not going to take the HIV medication, and that's their right to do that. They can't be forced into taking it. And when that person was released, he came into the clinic with his partner. It had been some time before he had an HIV review with a doctor, and his female partner was HIV negative, so we initiated a 3-drug PEP because he had a level of viremia, which was, I think, something like 15,000 at the time. So that's just one small example of why we would initiate 3 drugs. If someone asks you about PEP and it's beyond 72 hours, we need to weigh up the pros and the cons and the value of that. If it's a known situation, then I'd be certainly talking to our sexual health physicians to see, what's the benefit there, and is there a benefit there? If it is initiated, then we'd certainly be following that up very closely. We'd be looking at, and the reason for that is HIV virus, if it's already attached and we can't prevent that replication process and the infection happening, are we going to enforce a level of drug resistance if we start it after that infection has actually been, the process has started? So if we look at seroprevalence and epidemiology in Brisbane, if we're looking at men who have sex with men, it's approximately 8.8%. With intravenous drug use, and homosexuals, it's 29.2%, with other people 1%. Heterosexuals in Australia that are determined their HIV status through blood transfusion, very, very low. STI attendees 0.5%, and commercial sex industry workers 0.1%. So often people are very concerned. We have several calls at different times when people are actually leaving a brothel where they've actually had sex with someone, which has been with a condom, but the concern is so high around HIV, not STIs, but HIV in that context. And there's been complete protection used with that. So often it's about talking someone off a bridge and giving some education, and there's a high level of anxiety that's involved because there may be other partners involved beyond that situation. Okay, so these are recommendations for PEP exposure to a known HIV status source and what is and isn't recommended. So in the far right column, if we know that the viral load is known to be undetectable, then any of that contact is obviously, it's not recommended. Where we don't know the HIV source, or we know that the source has a detectable viral load, we would be looking at 3 drugs. And again, with receptive and insertive oral intercourse, it would not be recommended. And again, this is the exposure to a source with unknown status. So we're looking at the estimated risk of HIV transmission per exposure and what the PEP recommendation would be. So the management and advice when there has been an exposure, if someone calls into the clinic and they're asking about it, these would be the general things. So after sexual contact, if there's ejaculation either into the anal area, into the vagina, there's no douching after sexual intercourse. You may well, particularly sexual intercourse in the vagina, you may well wash any infected semen up through the cervical canal and up into the uterus. The recommendation would be not oral exposure, spit out blood or bodily fluids and rinse with water, wash wounds, irrigate eyes and mucous membrane, etc. Don't inject antiseptics or disinfectants into wounds and therefore cause any inflammation and ongoing potential risk. And there's not robust evidence around these, so certainly the explanation comes down to that. We'd be looking at the risk of pregnancy. That always needs to be assessed for people that are in a reproductive stage in their life where they may become pregnant. And that's with whether it's a known partner that they may consider continuing pregnancy or not. So we would always offer emergency contraception, and which is reasonably effective depending on the time of the cycle, and we don't always know that. And is there a requirement for ongoing contraception? Certainly. And we can give resources. That's certainly not the priority at the time, but it needs to be considered. The baseline and follow-up testing on day 0. Normally, we wouldn't be doing a lot of the STI testing at that time. However, it's a case-by-case basis. So this might be in a client that has never had a sexual health check or any STI testing at any time previously. They may have been sexually active for several years. It might be the first time they've ever had sex. So if this is his first sexual encounter, then doing STI testing today is pretty irrelevant. So we would be checking liver function and biochemistry to ensure that there's no renal compromise, that there's no liver function concern for us, and we can check hepatitis B immunity at that time, hepatitis A, hepatitis C, and these will all come down to their risk and the questions that we're asking you as well. At day 14, we'd be doing STI testing, checking for things, bacterial infection, chlamydia, gonorrhea. At week 4 would be the first time that we'd be doing the HIV test. So the earliest, with the robustness of the ELISA testing that we have with serology for antigen, P24 antigen and HIV antibody, the earliest that we would recognise it is at 4 weeks now. And with the rapid tests, the pocket tests for the ELIA testing that checks for antigen and antibody, the sensitivity with them is quite high in specificity, and we would usually find a positive result around week 4. Obviously, if it was positive or reactive, is what we term the result to be, then we would do a confirmatory serology around that, because you can get indeterminate results and false positives. We would talk about safe behaviours, and that's using condoms with a regular partner or for ongoing sexual contact during that 12-week period while we're monitoring people around their HIV transmission. And we would advise the normal things that you would expect: no needle sharing, no blood transfusions, sperm donation, that kind of thing around that time. We have the great benefit of psychologists at the sexual health clinic, so we can certainly refer people that do have HIV anxiety and other mental health concerns into our psychology support services. We have 3 female psychologists, and they're all brilliant. And sometimes that can be quite acute. People may identify, if I become HIV positive, there's a suicidal tendency. There can be a risk there, and that can happen if there is a positive result. Sometimes at that time, and there's been a couple of occasions when we've done an HIV test and we can do a rapid test at the time before we initiate PEP, we have identified that people are HIV positive, unknowingly, asymptomatic. The risk wasn't something that they featured in at some point. So clearly there's been a sexual risk or some other risk where the HIV has been transmitted to them, but they've not identified that prior to their presentation for this particular occasion. It doesn't happen very often, but it certainly has. So the assessment and the pathway when we're prescribing PEP, we look at the risk event, the time of exposure, and where they were. Sometimes people will travel, they've been out of the country and they've come home. I've recently seen a client who was on a business trip, married, heterosexual man, went out with his brother to dinner in China, went to a nightclub, was separated from his brother. The next thing he knows, he remembers seeing his brother across a room, talking to people in the nightclub, and the next thing he remembers is waking up in an alley. The next morning, his trousers were dishevelled, his underpants were gone, his wallet was not with him, his mobile phone wasn't with him, he didn't know where the hell he was, felt very hungover, and so he went to an emergency service, like a hospital service. They initiated 3-drug PEP for him, and then he arrived back in Australia, and I saw him at the Redcliffe Clinic. So a big part of that is talking about, a country of high prevalence, what the potential risk is. He has absolutely no memory of anything that happened, but he has had, at that point, the next day he had bloody discharge from his bottom. So, and we hear interesting stories about sometimes people will find these YouTube clips of where people have been sexually assaulted in these situations. So really traumatic things, and so he talked to his partner, and I offered for his partner to come with him so we can talk to both of them. When we have absolutely nothing is known about a situation, but you can imagine how traumatic that is. So we did offer him some psychological support if he wanted to talk to someone, because you can imagine with a potential or a known sexual assault, that's a very, very difficult time for people. So we talk about is the source known, their HIV status, and sometimes people will ask when there's unprotected sex, and sometimes not. Sometimes people will say, look, I'm on PrEP and it's all fine. And we've recently had a situation where someone's become HIV positive in that very situation, where they didn't feel that they needed to initiate PEP, and they've subsequently become HIV positive. The gender of the person that they were in contact with, what country they came from, or where that event occurred, had they ever had an HIV test, and how long ago was that? Was it negative, if ever? Have they ever been diagnosed with a sexually transmitted infection? And that's often why we'll do STI testing at baseline. And their hepatitis B or C status. Are they on PrEP? Was the contact on PrEP? And information about the client at risk would be similarly. We talk about pregnancy risk and contraception. Current medications, allergies, have they taken PEP before? What was their experience? Drug and alcohol history. So other things, obviously, that we need to take into account are if someone has liver concerns where their liver function is affected, or they may have renal compromise, because we do know that Truvada or tenofovir can have an impact on renal function. Okay, so this is the testing pathway, but again, that's in the PEP guidelines, so I won't bore you with that. We do know that the vast majority, probably 99% of people at week 4 when we do an HIV test with serology, that's going to be fairly definitive. If they're negative at that point, they're pretty much out of the woods. But we do know that for some people, they can take a little bit longer for that seroconversion and for us to identify antibody in their serology. So we do recommend that they come back in 3 months for that follow-up serology. So I've just put a bit of information up there about cost, so people know. Obviously, this is the Commonwealth Government subsidises PEP, that just gives you a little bit of an idea around costs. It's approximately $700 for Truvada for the 28 days, and if we use TDF and lamivudine, it's around $568. Tenofovir is pretty robust in it being a drug that seems to be quite good with prevention to resistance in viremia. But we do know there have been a couple of people that have been taking PrEP, and Truvada is the drug that's used in PrEP, and we do know that those people have become HIV positive, and when we've looked at the virus has actually been resistant to Truvada. And looking at the 3-drug regimen, I've just put a little bit around the cost and the range around that $500 to $600. And for all people that, particularly men that identify male partners and that may identify that they will continue having anal sex, and that sex may be without a condom, and that can certainly be preferred for some people, we certainly talk about transitioning onto PrEP for these people. We put it out there, we're not enforcing that, but it certainly goes, all of these modalities are continuing to contribute to the untransmissibility of HIV. So medications in the regimens and the interactions and other facts. So we do know that tenofovir is more tolerable than other options. It's a nucleoside reverse transcriptase inhibitor. There are implications. It's excreted by the kidneys unchanged by the glomerular filtration and active tubular secretion, and there is a dose adjustment if creatinine clearance is below 50. There's a new component that we're looking at called TAF, tenofovir alafenamide, which has a greater intracellular concentration and less renal implications, and so that in the future, maybe with more robust clinical evidence, we may actually have that as an option for PEP as well. It's not significantly metabolised by liver enzymes. The half-life is about 10 hours. The pregnancy category is B3 in Australia, which means it's for women that are pregnant. It's not recommended for use. It is known to cause a reduction in bone mineral densitometry, but we're looking at short-term use in PEP. So for people that have got existing osteoporosis, I'd certainly be talking to a sexual health physician around what their recommendation and advisement would be around that. It inhibits the activity of HIV-1 reverse transcriptase, and it terminates the DNA chain after incorporation into the viral DNA. So that is how it ideally prevents transmission. So we're looking at dolutegravir. It's an integrase strand transfer inhibitor. It's very well tolerated. It can be affected by liver enzyme-inducing drugs such as phenytoin, St John's wort, which can cause lower plasma levels because of that increased metabolism. Antacids containing magnesium and aluminium can affect absorption, obviously, and the advice would be to use either 2 hours before or 6 hours after taking the dose. With metformin, it may increase the level, so we would certainly be monitoring glucose levels for people that are diabetic. And with recent data, with dolutegravir at the end of last year, early this year, there has been some new data that's come out there for women that were taking it as part of HIV therapy. We've identified neural tube defects and the birth outcomes of some of the women. And so currently, women that are taking dolutegravir who may be considering further contraception or not, further conception, and maybe not taking contraception to prevent pregnancy from happening, we're having that conversation with people around this. I certainly have recently seen a client at Redcliffe who was in that situation where she and her husband had not determined that they're not having any other children, so we talked to her about, well, maybe we need to look at changing if you think that that might be something that you'll do in the future. Her partner's HIV negative. So, and it doesn't necessarily mean all women are going to have neural tube defects with their pregnancy outcomes, but it's a potential risk, so we need to provide information to people. A lot of people that have been on and are quite stable and happy on their antiretroviral therapy or their regimen often will determine that they don't want to change it. They've had maybe terrible side effects leading up to where they are right now. They've got a really good regimen and they're very happy with their drug. Don't break it don't fix it if it's not broken. I'm happy with it. My virus is suppressed. I don't want to change it. So, it's about having communication around that. So dolutegravir is excreted in the urine and faeces, and its half-life is around 14 hours. The primary mode of elimination is through the liver. So obviously, again, if there's any liver function problems, we need to be mindful of that. Raltegravir is an HIV integrase inhibitor, stops viral replication by the prevention of insertion of viral DNA into the host DNA. This information is taken by the Australian Medicines Handbook. It's twice a day dosing as opposed to once a day, and the absorption again can be reduced by antacids. There's a small risk of rhabdomyolysis with raltegravir, so we need to educate people. Any symptoms about myalgia, then please notify your clinician if it happens, and not to use with statins because that can certainly also have that risk of rhabdomyolysis. So the caution we give with clients if they're marathon runners going to the gym regularly, high-level athletic activity, because it can cause implications there. We check CK and renal function in clients reporting myalgia because we're always concerned about that cardiac compromise and potential insult. The half-life is around 9 to 12 hours, excreted in the faeces and urine, and it's pregnancy Cat C, which is contraindicated. Okay, so moving on to PrEP. I'm just mindful of our time and the time that we don't have. So some slides I might skim through a little bit just because there's so much information around it. So The objectives are we'll have an understanding of PrEP protocol, and we'll try and relate the guideline to clients in clinical practice, and I'll give some scenarios. Identifying clients that are at risk and in priority populations, and what the referral pathways might be for you. And certainly to consider maybe that being a part for people that are in your services with drug and alcohol. You may well identify that there's an HIV risk there, particularly for people that are having difficulty at a time where they're having some issues. You know, we certainly see people that are going through homelessness and mental health concerns and are really off the rails, and so we try and give information, and sometimes it doesn't work very well, obviously, but just to give people some information. And certainly looking at the Medicare ineligible clients that are coming in and coming off the QPrep trials now, that as of the 1st of April, it's PrEP's on the PBS, so now we're ending our trials in November. It will all be done, and so we need to have people established in some sort of pathway. So for Medicare ineligible clients, they'll be needing to access prescription through a medical officer. It's a little bit difficult for nurse practitioners to do it. We have to apply for particular access through the TGAA to be able to do that. So at the moment it's easier for a medical officer to be reviewing people. We can do everything, we just can't do the script. So essentially it's trying to stop the horse bolting, this part of it, whereas PEP is after the horse has bolted. So we're looking at treatment prior to the exposure to HIV, and the aim's to increase the prophylactic effect. So again, we're going back to that, looking at prevention as one of the key components of the reducing the transmission risk overall. We're giving PrEP to uninfected clients. Some are well, some may often have some other health morbidities that can have an influence and compromise that. And we're looking at people, we're taking HIV drugs to prevent that transmission. And you know, the drugs are fairly toxic. They do knock people around a little bit. Part of the components of the PBS are that we're looking at people's biochemistry, we're assessing them and screening them every 3 months, and that there is a moderate to high risk for their eligibility. So the evidence of the trials are the IPREX and PROUD studies, heterosexual adults of partners on PrEP, the TDF2, and with intravenous drug use in Bangkok tenofovir study. Transgender people in small numbers in the studies have been identified on PrEP, and IPREX suggests we're adherent to a PrEP regimen. It's very effective in transgender people, particularly transgender females. So we do certainly have some transgender people that are continuing on with PrEP and doing quite well. There's a wide variation of efficacy and prophylactic effect depending on the adherence to daily dosing. So as you can imagine, like diabetes, blood pressure, you name it, if people aren't taking it, it's not going to be there, it's not going to prevent it. And I've put in the PrEP guideline to the link. It's actually part of an article. It's in the Australia, there's a journal, Virus Eradication Journal, and it goes through information. It is very user-friendly to read. It gives you lots of information to read around questions that people might ask you. I find it really helpful. I've gone back to that several times just to have a bit of a look and to have a think about things, the what-ifs. So in 2011, the UN Declaration of Commitment on HIV/AIDS endorsed by Australian health ministers to be able to provide PrEP. So a couple of years ago, we put a submission to the government to subsidise PrEP. That was knocked back. Then the trials started, the QPrEP trials. The evidence is overwhelming to support that it does prevent HIV transmission, not STI transmission, but HIV transmission, and then the decision around that was that we would go, the trials will cease and it will go into the PBS as of the 1st of April. So the primary preventive initiatives are obviously condom use and safe injecting equipment, and PrEP being a biomedical strategy. There's others, intermediate HIV treatment for newly diagnosed clients to reduce their viral load to undetectable and therefore reduce the transmission risk. And with the new antiretroviral regimens we have, often we're finding by week 3 and week 4 for newly diagnosed people initiating antiretroviral therapy, often undetectable viral status is achieved by week 3 and 4. PEP for exposed clients, both for known and unknown HIV status, increased testing for those that are in a high-risk category for transmission for up to 4 times a year, and increased testing for STIs. In 2015, there were 73% of new HIV diagnoses were men having sex with men, 20% were heterosexual, 40% were from a high prevalence country or a partner from a high prevalence country, and 3% were identified intravenous drug use as being their potential risk for transmission. So with behavioural eligibility for PrEP, men having sex with men are considered a high risk of HIV if they are reporting at least one episode of condomless anal intercourse with a regular HIV positive partner or a contact that's not known, and they're not on treatment, or they may have a detectable viral load, or at least one episode of condomless anal intercourse with any casual HIV positive partner or unknown HIV status, and a male contact, that there may be rectal sexually transmitted infections. So, sorry, these are my mnemonics. So NG, Neisseria gonorrhea, CT, chlamydia trachomatis, syphilis, you would know. And that's at screening for PrEP in the last 3 months. If there's methamphetamine use, amphetamine use, and if there's likely to be engaging in multiple episodes of condomless anal intercourse with or without intravenous drug use or sharing. I was talking to Jim before the presentation, and certainly something that you're probably hearing about in your areas as well. There's more Chem Sex happening at the moment. So for people that are on PrEP, and the same with people on HIV medication, if people are in a situation where there may be several days where people are taking chemicals, they're not sleeping, they're having a lot of sex, usually unprotected, but they're not taking PrEP, it's not going to work for them. So these people are certainly going to be at a much higher risk of HIV transmission, and certainly STIs. And we've seen STIs, in particular syphilis, certainly elevate largely to the point that we're treating syphilis often more than maybe 3 times a week, sometimes 3 times a day. It's hard to keep penicillin in the fridge. So with PrEP, it's case-by-case approach. So consider sexual health, alcohol and other drug use history when we're taking histories. If you identify anyone or someone asks you about it and you need some extra help, there's this guideline. Hop on the phone and ring. There's the infectious diseases department at any of the hospitals. You can call up the clinic and talk to a nurse. If you're concerned about it, we'll give you advisement. We can give you advice around S100 prescribing doctors in the community, or GPs that may be available to do that, and we'll certainly give you some advice around that if you need it. So the personal circumstances of each client need to be taken into consideration when they're inquiring about PrEP. We identify who we may determine as high risk, and sometimes it's not always medium to high risk. There can be other extenuating circumstances around that that we may need to take into account. You know, there may be those situations where in relationships sometimes there's a power differential and people are unable to determine whether they do or they don't want to have sex, and we certainly have some quite complex situations. Some of the clients that we see in Redcliffe where they do have HIV positive partners, they're unsure about whether their partners are actually taking their medication, but their partners are also not using condoms with them, so there certainly are, you know, a HIV risk there. That doesn't mean that they will necessarily take it, but we certainly give advice and education around it. At the end of the day, if people determine they don't want to take it, then that's entirely up to them. Okay, so most of these things I think I've pretty much covered. So certainly for some women, if their partners are bisexual, that certainly increases their HIV risk. Some things to be aware of. Just mindful of time, so I'm just sort of screening a little bit here. Okay, so when we're looking at the trials and the evidence that have influenced PrEP being a modality that we're using now, certainly and looking at the behavioural modality around HIV risk, we look at heterosexual clients. Overall, we could say that they're quite underrepresented because often the trials are looking at gay men and the transmission rate there. So I want to be clear that this is not actually being exclusive of heterosexual people, men or women. We take everybody into to consideration, and sexual identity is also taken into consideration and the potential risk that that might pose. We assess alcohol use and the use of other drugs and the personal circumstances around that, which may warrant a prescription for it. And sometimes medium to high risks are actually not revealed to us. So, you know, it's not like a confessional. We're not the sex police. Sometimes people don't identify and don't want to report to us what the actual risk for them is. So we need to be mindful of that. I think probably in your areas as well. Psychology is a big part of what we do, and we don't want to cause any greater anxiety around this for people if they identify as having a risk. People that travel to a high prevalence country or identify that they may engage in sexual intercourse when they do go to the high prevalence country, certainly we need to be mindful of PrEP in those situations. People who inject drugs, there may be high risk if they report sharing and injecting equipment with people that may be HIV positive, or they are an unknown status in the last 3 months or maybe in the future. If people identify inadequate access to safe injecting equipment, we need to be considerate of that as well. So overall, back to the whole, I guess the bottom line is it's case by case. So part of our assessment is behaviour, sexual risk, alcohol and other drugs, personal circumstances. Okay, when we're looking at the safety of the drug, Truvada's been used in HIV negative clients. It's been reported in clinical trials with a follow-up from 1 to 4 years. There was greater than 2% of participants taking Truvada reported headache, weight loss and abdominal pain. They're the most frequent things that have come back. Overall, it's very well tolerated. And usually it's the first couple of weeks that people identify those side effects. We need to be mindful again of the risk to bone mineral densitometry and renal function. So if we're looking at dysfunction, Fanconi syndrome, reduction in bone mineral densitometry, chronic Hep B positive, we need to be mindful of that over a long period of time. And those conversations will certainly happen anytime someone comes in for their prescription. Now, some of these things I've already talked to you about. I've put in the link, that second point there, Green Cross Pharmacy. It's an online pharmacy, so for people that are non-Medicare eligible, that is one of the ways that they can actually upload their prescription. So the way that it works is they'll receive a prescription from a doctor, for example, in my clinic. You go onto the website, they'll need to upload a picture of the prescription by their phone onto the website to be able to order that. We're not always sure what country it's coming from. It can take anywhere from 2 to 4 weeks to come through, but the prices are quite competitive now. So one of our concerns that we've had is the trials are ending for people that may be studying, for example, in Australia, so they don't have Medicare eligibility status or a very minimal income. The trials have been great because they've been able to go onto the medication without any personal cost. And now, as those trials are ending, it's going to be, financially, that'll be around making those decisions. Do I afford to have food or do I afford to take PrEP? So sometimes those considerations need to be taken into account. So hopefully we'll be able to, in the future, there may be a better way to support people that don't have Medicare, but we're looking at the costs around ordering online can be anywhere from $20 to $30. The PBS, it's $39.50, with a healthcare card at $6.40 per month. So the requirements for me to prescribe it, clients need to be over 18, medium to high risk of HIV transmission, and there's a 3-month review process for continuation and risk assessment. Are people taking their medication? Can we help with their adherence to ongoing use with it? We check electrolytes, liver function, and urine protein creatinine ratio and urinalysis to assess for proteinuria. Okay. I've put, on that last point, I've put the Liverpool site. It's an HIV drug interaction tracker. So for people that might be taking medication for other things, whether it's high blood pressure or diabetes, whatever, you can actually go to the site. Are people familiar with this site? It's a brilliant thing. You can get an app on your phone. I just love it. You go on there, you can whack in all your details and it will give you some risk assessment there. You can use it for other drugs as well. Okay. I've put the PBS Authority link for anyone who wants to look at it. It does actually have the authority code, who you can prescribe it for around the repeats. So with the PBS, it's a supply of 30 tablets per bottle with 2 repeats. It has the nurse practitioner prescribing, and it also has medical prescribing authority details on there as well. So when people first start on PrEP, we advise them they need to take 7 consecutive days of medication before they will have a chemo prophylaxis cover to prevent against HIV transmission if an exposure happens, e.g. unprotected anal sex. The maximum intracellular level of the drug occurs at approximately 20 days, and if transitioning from PEP to PrEP, then we need to be mindful of doing their HIV testing at 4 weeks as they're transitioning from one to another, and then again at 3 months to ensure that that latent transmission hasn't occurred. We talk to people about seroconversion symptoms. If you have any of these things, give us a call, come on in. We know it's very rare that HIV transmission will occur, but sometimes it does. We've had a couple of people that have gone through their workup and part of to start the actual QPrEP trials. And unfortunately, by the time they got an appointment to come in, because it's been such a heavy sought position on those trials, that they've actually been diagnosed HIV positive. So sometimes it's about timing, which has been unfortunate. It's safe to use in Hep B co-infected clients with viral suppression, but again, we need to be really careful and talk to our liver specialists about stopping it, because we don't want a flare to occur. Yeah, and so there's no resistance to TDF or emtricitabine and HBV genotypes. So women are advised to adhere to daily dosing to maintain a high drug level in the vaginal and cervical tissue. There's no data available regarding drug levels in penile tissue, which relates to men who are having insertive anal intercourse that I could find. There is information in the guideline that I find really helpful when people are asking about on-demand PrEP, and that is, I'm not sure if you've heard about it, so in the UK apparently that's how, before it became a thing, that's how people were actually taking it, probably because of the expense and the availability. So it's a modality where if people are not having anal sex all of the time, but they think they may have an occasion this weekend where it might happen, they would take 2 tablets 2 to 24 hours prior to that potential risk event, and then 1 tablet daily for the next 2 days. Now, if that is the next sexual event or the potential risk is going to happen within 7 days, the loading dose would be 1 tablet and continue with the regimen. If it's more than 7 days, then they would load again with 2 tablets on that first day. So looking at that and the data that came out of what I could find in the trials, there was 86 to 97% risk reduction in HIV transmission in the people that were using that. The guideline for PrEP and on-demand use in Australia is not there, so the recommendation from ASHM is that we don't use it that way. This information is, however, available. People are smart. They're going to find it, they're going to use it the way that they want to. Overall, looking at, and people kept diaries of the trials, so looking at the number of tablets that people were taking for the length of time, they needed to have at least 5 tablets in any given week to prevent HIV transmission. Less than that, we saw an increase in HIV transmission for those people. And the on-demand preference were in AM PrEP, that was the trial in the Netherlands, Be Prepared in Belgium and in New South Wales. So on-demand data in MSM and transgender female clients were in the IPA-GAY and IPA-GAY open label extension. Okay. So I'm going to try not to whiz through, but I will have to whiz through a little bit about HIV, and we'll certainly look at the treatment as prevention and the new antiretroviral therapies that are available. So the overview of the current data in Australia, prevalence and who should be tested, those priority groups, which I'm sure that you can identify, and what's new in ART. Now, we might skip we might skip. I was going to play a little YouTube link, which actually it's there in your resource if you want to go onto that YouTube link. It only goes for a couple of minutes, but it actually is a really good visual representation of how HIV docks to CD4 cells and how it integrates into our DNA, buds, and then is released. So it's through that budding and the release, and that's how CD4 cells die, and we start to lose CD4 cells. So the data, when do we have to stop, Jim?
Within the next 5 minutes.
Okay. So the new data in new infections in 2016, we're looking at approximately 1,013, and comparatively looking in 1999 there were 700, and in 1987 2,412 at the peak of HIV being identified as a new virus. So obviously diagnosis and stability has happened over, certainly over the last 5 years. There's been a majority of male people that have been identified in HIV diagnosis and more female and less female diagnoses. In 2016, the number of people diagnosed with HIV reported category exposure, 70% were male to male sex, which is approximately 712, heterosexual, 21% of 209, intravenous drug use of men having male partners, and injecting drug use, 5%, which was 51, and injecting drug use alone was 1%, which was 14. Now, like, I guess, hepatitis B and hepatitis C, we're finding that there are a percentage of people that don't know, that haven't been tested, but we suspect are HIV positive, but they don't identify a risk or don't want to be tested, and they would be HIV positive. So looking at the HIV surveillance report in 2017, when we're looking at people that were living with HIV in Australia, is 26,500, which is 89% of those are diagnosed. 95% of those diagnosed are in managed routine care, like sexual health clinic or infectious diseases departments or GPs, and 86% of those people that are managed and engaged in care are on antiretroviral therapy. 93% of those people on antiretroviral therapy have suppressed viral loads. There's an estimated 11% of people that are living with HIV who are undiagnosed and unaware, which is approximately, in 2016, that approximation was 2,796. There's a higher proportion of people that are undiagnosed, that are heterosexual and don't identify their risk. And we certainly see people in a higher prevalence country, there's 27% in Southeast Asia, and in Aboriginal and Torres Strait Islander people, 20%, women 13% of undiagnosed estimation. So why should we test? Testing and diagnosis enables the management of the virus to reduce that viremia and obviously that untransmissible risk ongoingly. Treatment enables immune restoration for people that do have HIV, and that reduces their potential risk for other morbidity and potential mortality. Continuing viral suppression can mean a normal or near normal life expectancy and quality of life that goes with that. A reduction in transmission is obviously a huge reduction in the overall economic risk to Australia. So access to treatment, if it's accessible for all, and modifications for children. We certainly have HIV paediatric units in our large hospitals that are very well set up just for paediatric HIV infection, and we do have a transition pathway for people coming in as they're turning 18, coming into our service as well as adults if they choose to. Overall, antiretroviral therapy is well tolerated, and 30 to 35 years ago the pill burden was 30 to 40 tablets a day people were taking. Now often it's down to one. And we're looking, the research now is also looking at intramuscular injection, which may be once a month that they're having their treatment, which for some people, that constant daily reminder of having to take a tablet and being aware of their self-stigma around I have HIV, this can certainly help, hopefully, with their overall general health. Okay, a lot of this we've covered, so because we're time poor, I will just briefly go over this. So people that we already know. We're always testing, in Australia, we test pregnant people at the start of antenatal screening. It is a recommendation that we do that again around 28 and 36 weeks, just to ensure there's not been a transmission that's occurred during pregnancy. Sometimes it's not always identifiable in risk infections, and we are seeing, with a little bit of an anecdote, we are seeing some congenital syphilis in the last couple of years. So with that, we certainly need to be mindful of HIV testing as well. So any client that's travelled to a high prevalence country and reports high risk behaviour, which may include condomless intercourse with sex industry workers in different countries, surgery and tattooing, and people that are reporting partner change, whether that's heterosexual or male partners. There's a high proportion of HIV notifications in Aboriginal and Torres Strait Islander populations, and we're finding heterosexual would be 20% and injecting drug use 14%. Okay, it's kind of whipping through a little bit of information here so I can cut to the chase. Okay. When we're taking a client history, obviously we need to be non-judgmental for anyone and any information that they give us. We certainly do hear people say that they have been to a GP and been made to feel that that any sexually transmitted infection was something that meant that they were promiscuous or dirty in some way, and that can certainly set people up into a very negative mindset about going anywhere else to have STI testing. Often we do get compliments from clients to say it's a very positive experience in the sexual health clinic where they felt they could say anything to anyone and there was never going to be any implication on what they said or the treatment that they were given or the care. So it's good feedback, but we certainly know that there's stigma that's still out there in the community. Okay, we discuss client concerns and we don't assume heterosexuality of anyone. We try and address things as a holistic approach and lifestyle, mental health concerns, anything else that's going on in people's lives. Sometimes even, if people are in a group sex situation, or that may be, swingers groups, we just need to give that education for people around. In that situation, you're not going to know about infection status and contact with partners within that group, so be mindful, particularly women, if they're having sex with bisexual men, that is the potential risk for them for HIV and STI transmission. So there's been stigma attached to homosexuality and the link to HIV, but one does not mean the other, and it's not an inevitable outcome. So there's the testing policy has been updated. We used to go through great lengthy counselling. We don't need to do that anymore, but we do need to make sure that there's an informed consent around HIV testing for people when they're coming in or when we're offering that. We may identify a risk, but that doesn't mean that they have to give consent to have an HIV test. And that situation, then I would be just mindful of trying to impart some information around the potential risk for you in this situation. Could well be that you may have been exposed to HIV and giving information around that, and hopefully that person will come back at some point and have an HIV test. So I've given another testing portal link there for people if you're concerned about testing and what different situations are there, what's considered a legal order and when to test, because sometimes there may be an emergency if there's been a trauma or people need to be taken to surgery or give blood. If there's a blood transfusion that needs to happen, HIV testing is going to be a part of that. Do we get consent from someone's partner? Do we get consent from the next of kin? If we don't have any of those people there, we need to make that informed decision as a medical clinician at that time. Point of care testing, the rapid tests now are available in the community settings. Rapid Clinic is certainly one clinic within Brisbane. They're in a couple of places now, and you'll get your HIV result in 10 to 20 minutes. They can also do rapid testing for syphilis as well. It's a screening test, it's not diagnostic, but if it's positive, serology for confirmatory HIV testing is required. There are limitations, so if we do the pocket test within 3 weeks of a potential risk, we may get a negative result. It may be too early to detect, and we just need to make sure we get that information to the person at the time. Everything is around risk assessment to determine if it's an appropriate test to do for that client. We talk to people about over-testing. We have some people that come in for testing who aren't even sexually active. They're so concerned about HIV. So it's really giving them some information to help with that anxiety. Sometimes they may need a referral to our psychologist to talk about that and where that risk has actually come from. So we talk about results, negative, an invalid test result, and what's reactive. Reactive is positive. We talk to people obviously beforehand, particularly if we identify a high risk and we know that that's going to be positive. Do we need to stop? No? Okay. Okay, the results we give, certainly in our clinic, we're giving them face-to-face. If that person, sometimes they're flying out of the country the next day, but they just need to know what the result is, we can negotiate. Well, tell me what time to ring. I can send you an email just so you know. Sometimes we can't always do that in the time frame that they need that to have. And then we determine at that time by the client and by the tester, spell check there. In the community, in rapid clinics, the testing is actually done by volunteers, and in other areas, I'm sure, in overseas where you've got resource poor settings, healthcare workers are doing these tests. They're educated by clinicians, but they aren't clinicians. The information needs to be delivered in a sensible, sensitive and respectful way, respectful of culture, of their gender, in a language that people understand. So if you need an interpreter to talk about this, get an interpreter on the phone. Excuse me. Okay, so some of the resources I've talked about before. If people are HIV positive, we have a great organisation, Queensland Positive People, that do have caseworkers that can give people information. Two Spirits is an Aboriginal and Torres Strait Islander program that's run through the Queensland AIDS Council, which can also give support. We talk about safe sex practice and advice and contact tracing, and there's an HIV public health unit specifically that you can engage with around contacting people that may have been identified as a risk for HIV transmission in the community. Why do we do contact tracing? Obviously we want to try and inform people that they may have been in contact or they may be a risk of passing on infection to people, and that enables them to have testing. We can diagnose HIV if it's there, because some people will be blissfully unaware and asymptomatic, and we can talk to them about treatment as management. There's obviously a sexual risk and risk with injecting drug use as well. So the aim of all of this is to interrupt the ongoing transmission of it. So the UN AIDS targets are 90-90-90, and that determines by 2020 90% of people will be diagnosed with HIV that are HIV positive. 90% of those people will be on antiretroviral therapy, and 90% of the people on therapy will be virally suppressed. And Australia is tracking well, and we're on to the third 90. And there is, I think by 2030, the aim is that there'll be 95, 95, 95. And for some people, as you would know in your areas, some of these things are always going to be a challenge. Okay, so you've got the resource. I'm not going to go through all of those things, but I've put down some of the drug classes, and the value of the YouTube clip is actually these drugs identify where in the HIV transmission process that the drugs actually work, and that's how it prevents viral transmission. So that's just an overall representation of the life cycle and where the medication actually works, which I'm not going to go into because we're time poor. So combinations, usually when we're starting people on HIV medication, we have a dual nucleoside backbone, so 2 NRTIs and a third drug from another class. So common combinations might be an NNRTI, we might have a protease inhibitor, and it may be boosted, and boosting increases the concentration of the drug to help suppress viral transmission, and we can have 2 NRTIs and 1 integrase inhibitor. So the side effects, there's advantages and disadvantages of each regimen, and for people that might have other morbidities, for example cardiovascular disease, diabetes, liver complications where they may have liver function problems, hepatitis C, cirrhosis, etc., we need to look at the medication that we're giving to ensure that it's not going to contribute to that. One of the main components of talking to women is looking at their contraception and making sure the drugs that they are prescribed, if they're liver enzyme inducers, then they may well make different contraceptives ineffective, for example, the pill. But long-acting reversible contraceptives like IUDs are not going to have an impact on their liver or their cardiovascular health, and they are certainly an option. Okay, some of these things I've already discussed when we're talking about changing people onto a more simplified regimen or a newer regimen where we know that there's going to be less implications for cardiovascular health and renal health. Some people don't want to go on to that, but two of the new ones that I thought I'd very quickly mention are Gelaca, which is BD dosing, and it needs to be taken with food. It's not yet on the PBS, and Biktarvy is not yet on the PBS, but it's the new kid on the block. So it's taken once a day. Food is not a requirement, so you can take it at any time, and there's less impact on kidneys, on bone health and cardiovascular health. There's limited data though on pregnancy outcomes, and one thing I would like to mention is that often when we start new antiretroviral therapies, it may not be until 5 years down the track that we actually find, well, we didn't know this 5 years ago. So things like lipodystrophy and lipoatrophy, those things were found out after the event. We've tended to move away from medications around that now, but I just thought I'd mention that as well. There's low drug-drug interaction, and there's a low resistant profile with this. So I think that's about it really. Will we stop there, Jim?
That sounds good. Thank you very much, Jacqualine McLellan.
Thank you, Jim.
Unfortunately, just because we ran over, a lot of people have had to leave the room, so I'll ask if there's any questions.
Thank you for staying.
Yeah, I think it's really exciting to see, being a clinician that was around when HIV first came into the headlines, it's really exciting to see the changes. And I'm really hopeful that that's going to have an impact on the stigma that's still associated with the condition. It's a bit of a shame to see that STIs might be on an increase as a result of some of the prophylactic stuff that's happening. You mentioned at the beginning that in prison sometimes people will not take their medication when they go into prison, which I assume is in relation to the stigma associated
and
with
visibility.
Because of that window of 72 hours being so important, do they actually administer and commence in prisons if that's something that does get raised from them?
Yeah, we can. We've recently, in the last couple of weeks, had a client that's wasn't originally a client of ours but has gone into the prison system and was diagnosed just prior to going in. So yeah, and we talk to people about that. We don't want people to become terribly anxious about it. So often if it's antiretroviral therapy or a combined regimen that doesn't develop resistance, we can restart when they come out. Often it's about there's very little privacy, so why are you getting a medication? Why are you taking this? And we have had a report recently for the HIV Public Health Unit that there's HIV stamped on this particular prisoner's medication folder. That outs this poor man. So, there are a lot of difficulties around that. So, yeah, we need to be mindful of resistance, but often they're quite robust and we can restart again or look at different regimens.